Morning, everyone. I do want to thank the program chairs, Dr. Vitale, Dr. Tomaszewski, for allowing me to present on this topic today. And I also just want to point out that it looks like we're starting with an important joint, the shoulder, and going on to a more important joint, the elbow, and we're landing on the hand today. So I'm glad to be in that series. We'll move forward. I want to talk to you today about this innovative technology that has really changed my practice in the past year and a half. And it's how we treat the most common diagnosis we see as hand surgeons. That's carpal tunnel syndrome. I have no conflicts. I am going to show you some vendor-specific instruments, but I have no financial conflicts with them. One disclosure, I am the orthopedic medical director for Modernizing Medicine. So we have three main themes for our agenda today. It's very simple, but I'd like to start first with what is carpal tunnel syndrome, which I think we all know, but I just want to recover and make sure we all understand it. The second is how do you make the diagnosis? And lastly, what we're going to focus on is what are my treatment options? This is an AI-generated picture of carpal tunnel syndrome. It's interesting. We see AI everywhere now. There's no real use of AI in hand surgery at this point, but you can see they spelled carpal tunnel wrong. So I don't know if we really want to trust that at this point. So carpal tunnel surgery is really based on a symptom that becomes present when the carpal tunnel nerve, the median nerve, is pinched. And that nerve is in this tight space that we literally think of as a tunnel. And there's all these other things in there, mostly tendons and other, possibly some inflammation. But the nerve gets pinched because other things are inflamed and it's a confined space. So you'll see that the yellow nerve here runs through, it goes underneath this transverse carpal tunnel ligament. When it's pinched, you start to feel some symptoms. It's very common. It is the most common compressive neuropathy of the upper extremity. It's also one of the most common causes of days lost from work. In fact, it's 3% across the worldwide population, so it's affecting 240 million people worldwide. And there's a very good chance that you're probably one of the people in the room. So, maybe 5 of us or 10 of us here in the room. What does it feel like? Most commonly, people describe it as pain, paresthesias, numbness in the radial 3.5 digits, which just means the thumb, the index finger, the middle finger, or part of the ring finger. If it gets bad, if it gets severe, you may also see some loss of dexterity, which is when you might drop things, you might start to feel like you can't do buttons, you can't do fine motor activities. No one really knows the cause of carpal tunnel syndrome, but it is associated with at least a few things. Traditionally, we thought of it as repetitive maneuvers were associated with it, like keyboard or typing. We know it's also highly associated with pregnancy, arthritis, hypothyroidism. We talked a little bit about diabetes this morning. Certainly trauma can cause it if things are inflamed, and finally obesity. All right, so how do you make the diagnosis of carpal tunnel syndrome? The mainstay of diagnosis is still a clinical one, which means signs and symptoms. And when you come to the office, I might take a look and say, well, do you have the presence of 2 or more symptoms? So on the right column here, this is a set of symptoms as described by the clinical practice guidelines of the American Academy of Orthopedic Surgeons. So it's been vetted by all the orthopedic surgeons. And they said that if you have 2 or more of these symptoms, like nocturnal paresthesias, numbness of the median nerve, ringing or shaking of the hands, sensory digital symptoms, you probably have carpal tunnel syndrome. Then what I would do is, if you were a patient, I would have you also test for clinical signs. And that means using some provocative signs like a Tinel sign, where you're tapping on the nerve and you see if it makes like shocks to your fingers. The most sensitive sign is actually Durkin's compression test. So that's a very simple test where you actually put pressure on the nerve and you hold it for about 20 seconds. That's the best way to actually check. And if your hand goes numb, you probably have carpal tunnel syndrome. If it's severe, like I was saying before, you may have some thenar atrophy. So thenar atrophy is when the muscle around the thumb starts to kind of sink in. And that's because the brain can't send to that muscle a signal anymore, and then it kind of atrophies and wastes away. And then finally, 2-point discrimination, a little bit of an older test, but we might try to check to see if you can tell the difference between 1 little spike versus 2. All right. So if we suspect or probably know that you have carpal tunnel syndrome, the next step is traditionally a confirmation test, which means let's check. Let's see if you actually have it. And traditionally, the best way was electrodiagnostic testing. What that means, and also what we talk about when we talk about electrodiagnostic, is something called a nerve conduction study, or an electromyography. So those are NCS and EMG studies. Many of you might have heard of it or worked with patients that have had this. It's a way for us to get objective data on nerve function. Patients come back and tell me it's uncomfortable. They usually say it's about 45 to 60 minutes. There is a non-zero high false negative and perhaps false positive rate. So what that means for us as clinicians is it might be wrong. So you may have a positive test that shows you have carpal tunnel, but maybe you don't, or it misses when you do have carpal tunnel syndrome. So it's certainly not a perfect test, but we used it a lot, especially probably over the past 2 decades. Ultrasonography has changed this for my practice, and the reason is it lets you see the nerve immediately when you come to our office. So let me see if I can play this video. This is a video of me using the device that I would use every day for you if you have carpal tunnel. You come in and I'm holding this portable ultrasound device and it's connected wirelessly to my iPad. I'm scanning a wrist and I'm pointing out to this patient that I could see their nerve. And the reason why this is important is when you see the nerve, you can measure it. And what you're really looking for here is something called the cross-sectional area. So I can measure your nerve immediately as I'm seeing you, and I could tell you and confirm whether or not you have carpal tunnel syndrome. This is a normal cross-sectional area of a nerve. So you'll see here in the green oval that it's about 10 or 11 millimeters squared. This has been vetted through many studies in literature to know what's normal or what's not. If you have carpal tunnel syndrome, this is what it might look like. So it measures as 21.44 in this patient of mine. So 21 millimeters squared is almost double of normal. And you can imagine it's sort of like stepping on a water hose. If you step on it long enough, the part that has pressure on it kind of builds up and gets expanded and gets large. There are certain cutoffs we might use. In my practice, I use 11, but if you raise or lower that, you can capture more patients or you can capture less. So that's another way of saying the threshold can affect your sensitivity and also your specificity of the test. But when you compare it to the traditional tests like EMG and nerve conduction studies, it's actually very good, if not better. So they've done multiple studies on this. It's a great tool. It doesn't hurt. It doesn't take an hour. So it's really changed the way that I confirm if you have carpal tunnel syndrome. It also saves you time. You don't have to go to another doctor. You don't have to schedule that appointment. So it's something we could do right in the office. All right, so the crux of this talk is really treatment options, and I want to talk you through some of them. The traditional ones are very easy to talk about. You wear a carpal tunnel brace. You can get that at a pharmacy. You might even try some anti-inflammatory medications to see if it calms down your inflammation. If it works in certain cases, like for example, if you have carpal tunnel that's severe but you don't want surgery, then you could use steroid injections and you could feel better with those kind of cortisone shots. As of today, there's really 3 ways to do surgery for this, and I'll talk you through all 3 of them. The most traditional one is here on the left. It's an open surgery. It's very direct. It's very simple. We just get to the ligament that's causing the problem, that's pinching your nerve, and you just cut it. It's usually about 2.5 centimeters. It's not very big. It certainly heals well. But then we thought, well, let's improve outcomes because maybe we can use a smaller incision. So a lot of surgeons moved on to endoscopic. Endoscopic is here on the right. You'll see it's a different spot in the hand. It's less invasive because you don't have to cut through the kind of thick palm tissue of your hand, and it tends to heal a little bit better. So this is a photo of a real patient in the operating room. We're doing endoscopic carpal tunnel release, and this is what it looks like whenever you're doing the surgery. So this is the view of the camera in the carpal tunnel. On the top at 12 o'clock, you see these fibers that are nice and shiny white fibers. Those are the fibers of the ligament. So we're inside the tunnel. I'm going to play you this video. We're scanning to see what it looks like throughout the whole thing. You'll notice the cannula is clear, so I'm going to take a pause right here and point out that you can actually see the nerve on the right side of the screen so you know you're safe. And then at 12 o'clock, what you see is an endoscopic knife. And it's a special knife because it's very sharp, but also when you push, it doesn't take much pushing, it cuts. So you'll see here when I'm pushing here, it actually cuts the ligament, and then the ligament springs open because there's so much pressure on it that it relieves that pressure, and now you have this nice wide gap. And I'm just showing there that it's very complete, and it's typically very, very successful. This is a patient of mine I just took maybe a couple weeks ago. She's 8 days after surgery. She had it done on both sides. And this is how it usually looks. You can see that I use dissolvable sutures, so they're a little red, but they feel good for this patient. And a lot of times people say that the nocturnal symptoms, the symptoms that wake them up, feel better the night of the surgery. So that's the best part about treating this, because you can actually make an impact fairly quickly. So moving on, the outcomes for endoscopic was really controversial in the beginning. They thought that maybe it's too risky, you can't see things, you might cut things you don't mean to. But it's been proven over time, over many studies, that it's faster return to strength. It is faster operative time. There's no difference in complication rate. It's probably less painful. And you can get back to activities like work fairly quickly, within 9 days or so. I want to focus on this because this is really why I thought this talk was important. So ultrasound has changed the way I diagnose carpal tunnel, but it's also changed the way that you can treat it. And this is not to say it's for every patient, but in the right patient, an ultrasound-guided carpal tunnel release can have even less invasive effects and just as effective treatment. So this is a surgery performed on an awake patient. I'm using a large ultrasound machine in the OR. And I take a probe that's sterile, and you can see that I'm scanning the wrist. And as I'm scanning the wrist, I can see everything in the carpal tunnel, including the median nerve. I can see the branches of the nerve. I can see the motor branch. I can see the way that it splits distally into digital common nerves. And I'm using some landmarks here. But the reason why this has become a very interesting and perhaps better solution for me is that it lets me use this other tool. This tool allows us to make an even smaller incision on the wrist that is so small you actually don't even need sutures to close it. And patients here tolerate this very well awake. So you'll see I'm giving an injection here. I'm talking them through this whole process. Sometimes we're chatting and just joking around, but a lot of times they do very well just by numbing the area and then using this instrument to do the same work. So I'm going to take you through this diagram. So this is essentially what I'm doing when I use this technique. I identify the major structures, so I'm going to point them out to you just so you have a sense of what those structures are. The transverse carpal tunnel ligament, which we've already talked about, the median nerve, which is this yellow structure. Importantly, we also look at the ulnar artery, and this is something that has changed as well. We used to never pay attention to this artery, but sometimes it's very close to that ligament. So with ultrasound, you can actually see it. You can see it pumping, and you can see exactly where to put your knife to make sure you don't damage it. So this instrument comes in through a small incision, literally 1 to 2 millimeters, and it comes in, and it actually deploys this very ingenious tool by blowing up these balloons that separate the area that allows me to then deploy a knife that comes in, and it's a different knife. It's a kind of a pull knife that allows me then to cut the ligament. So you can only be a candidate for this if you have the safe anatomy or the right anatomy. So I'm not doing this for every patient, but I'll show you the difference here because it has changed some of the results that I've seen. This is an example of our team in the OR. I'm using this device, and this is the wound. It's very small. It's about 2 millimeters. You leave with what we say is kind of an occlusive dressing. It's like a Band-Aid, but you could shower right away. People drive home the same day. There's no sedation involved, so it's a very quick procedure. And this is 10 days afterwards. So 10 days afterwards, this is, by the way, a different mark, but this is their incision. So this is a patient who had it done on both sides. It's hardly visible on some of these wrists, so I've been very happy with the results. Again, it's not for everyone. If you had it done endoscopic, it works great. If you have it done open, it also works. But I think it's another tool for us to use. And in fact, it's a very highly effective tool. People get back to work within 3 days. They're satisfied. They have very little intraoperative pain. So I do want to say that you never really want to be the first person doing a new technique. So I watched this come out over the past couple of years, and it spread across the country. But I was very hesitant to do it because I didn't know if it would work and if it was the right thing for my patients. But as I saw that it was very established in hand surgery, I was invited to be the first person in Connecticut from here, I think all the way up to Hartford to do this. So I think it's a technique to consider. It's certainly I wouldn't say it's the best way to do it yet, but I do think it's a very good way to do it. And I also invite you to check it out at our Sonics booth. So Sonics is the vendor that supplies this equipment. I have no relation to them, but they do have an ultrasound machine. If you have a few minutes and you want to be scanned, Kathy is a very good ultrasound technologist, and she could just let you see what it looks like whenever you get your wrist scanned. That's it. Thank you.